Hi guys, welcome back. Today we're going to talk about hypertension. So this is part of the cardiology series for Internal Medicine 1. So let's first define what hypertension is. So hypertension, we have different definitions based on the guidelines that you're using to define what hypertension is, and based on different organizations they have different definitions. So the one that we commonly use in our university is the American Heart Association definition. So in this definition of hypertension, we can't base it off from one single reading, so we have to obtain two readings on two different occasions, and we have to average those readings. So it's an average of two readings on two separate occasions. So normal blood pressure in this definition means that our systolic blood pressure is less than 120 and our diastolic blood pressure is less than 80. Elevated blood pressure means that our systolic blood pressure is between 120 and 129 and our diastolic blood pressure is between 80 and 89. And then we move on to stage 1 hypertension, which means that our systolic blood pressure is now between 130 and 139, and our diastolic blood pressure is 80 to 89. And then for the second stage, second stage hypertension, we have greater than 140 systolic blood pressure and greater than 90 diastolic blood pressure. So that's the definition. And it's important to note as well that we can have isolated systolic or diastolic hypertension. So we can have hypertension just in one of the elements, so systolic blood pressure or diastolic blood pressure. So that's called isolated systolic or diastolic hypertension. Another thing is that we need to be able to exclude two important things. So we need to be able to exclude white coat hypertension and mask hypertension. So white coat hypertension means that when the patient comes to the clinic or to the office or to the hospital, we get really high blood pressure readings. But when they're at home, their blood pressure is actually normal. So we need to be able to exclude this. Another one, which is more dangerous actually, is called masked hypertension. So masked hypertension is the opposite. So when the patients come to the clinic, they have normal blood pressure, but when they're outside of the clinic, their blood pressure is like sky high. So we need to be able to identify these kind of patients. And the way that we diagnose or exclude these is we do a 24-hour ambulatory blood pressure monitoring. So that's like the gold standard actually in diagnosing hypertension and in excluding masked hypertension and white coat hypertension. So we have two types of hypertension. We have essential or primary hypertension, and we have secondary hypertension. So these are actually linked to the causes of hypertension. So for essential or primary hypertension, this actually accounts for 95% of the hypertension cases that we encounter in clinic. And this is most common in people ages 25 and 50, especially if they have like a strong family history of hypertension. One of the causes of primary or essential hypertension is an increase in sympathetic nervous system activity. And when we increase sympathetic nervous system activity, that means we increase the release of norepinephrine and epinephrine. And these hormones, they bind onto the beta receptors in the heart, so in the SA node, in the AV node, and the myocardium. So when they bind to the SA node and the AV node, they increase heart rate. And when we increase heart rate, we increase our cardiac output, because cardiac output is heart rate times stroke volume. Also, when they bind to the myocardium, that increases contractility. So when we increase contractility, we increase stroke volume, which increases cardiac output. So we've increased our cardiac output now, and increasing cardiac output will increase our blood pressure, because blood pressure is cardiac output times total peripheral resistance. So you see, in these mechanisms, we increase our blood pressure by increasing heart rate and increasing contractility. So that's one thing that the sympathetic nervous system does. Also, by the way, our blood vessels, they have alpha receptors. So epinephrine and norepinephrine, what they do is they bind onto these alpha-1 receptors in our blood vessels, and they make them constrict. So constricting our blood, vasoconstriction, increases the total peripheral resistance. And increasing the total peripheral resistance increases the blood pressure. Why? Because blood pressure is cardiac output times total peripheral resistance. So if we increase total peripheral resistance, we increase our blood pressure. So that's another way that the increase in sympathetic nervous system activity increases the blood pressure. Also, norepinephrine and epinephrine, they stimulate JG cells in our kidneys. Okay, so these JG cells, when stimulated, they release renin, and renin breaks that. Well, renin converts angiotensinogen released by the liver to angiotensin I, which then goes to the lungs and gets converted to angiotensin II by an enzyme called angiotensin converting enzyme by ACE. Okay, so when we stimulate the when we stimulate the JG cells to release renin, we produce angiotensin II. And you know that angiotensin II does a lot of things in the body to increase blood pressure. Just to recap some of the actions of angiotensin II, which help increase blood pressure. So that includes the vasoconstriction of the vessels. So when we vasoconstrict the vessels, we increase total peripheral resistance, which means we're increasing blood pressure. The second one is the release of aldosterone. So angiotensin II triggers the release of aldosterone from the zona glomerulosa in the adrenal cortex. And aldosterone increases the reabsorption of sodium and reabsorption of water. So when we reabsorb sodium and water, that increases the blood volume, which increases blood pressure. The third and final mechanism is angiotensin II triggers the release of ADH from the posterior pituitary gland. And what ADH does is it increases water reabsorption. So again, when we have more water reabsorbed, we increase our blood volume, which then increases our blood pressure. The next potential cause of essential or primary hypertension is the increase in the renin-angiotensin-aldosterone system activity. So this can be heightened in patients, for example, with diabetes with high insulin levels. The next one is like an increase in sodium retention. So when we retain more sodium, we retain more water, and therefore we increase our blood volume. An increase in blood volume means increase in blood pressure. But because of the sodium retention and the water retention that comes with this, with that increasing our blood pressure, because we already have a high blood pressure in this case, we don't stimulate renin release, because renin is only stimulated if we have a low blood pressure, remember? So in this case, if we have high sodium retention, we will have like low renin. So we actually call this low renin hypertension, and this is most commonly seen in patients who are of African American ethnicity. And finally, age can actually cause essential hypertension, just the fact that we're getting older. So the thing with age is that when we get old, the collagen in our body decreases. So the collagen in our vessels decrease, and we get more deposition in the vessels. So with less collagen and more deposition in the vessels, we decrease the compliance of those vessels. We decrease the distensibility of the vessels. So they're not as elastic, basically. They don't open up as easy. So this means that they're very stiff, they're very rigid, and therefore they're very resistant to flow. So we increase total peripheral resistance as we age, and therefore we increase our blood pressure. Before we move on to talking about secondary hypertension, I just want to briefly mention some of the risk factors for essential hypertension or primary hypertension. So we have obviously increasing in age, high insulin, like in the case of diabetics, smoking, family history, high levels of LDLs and high levels of triglycerides, high body weight, high stress levels, high sodium diet, as well as like low physical activity. Moving on to secondary hypertension. So this accounts for like not the majority. So it accounts for 5% of the total hypertensive cases we see in clinic. And this usually is very like sudden. So it happens in young individuals less than 30 years of age. And it's usually very sudden, has a fast onset, usually severe when it comes. and usually it's refractory to multiple different medications, so more than 3 different medications. So secondary hypertension can have a lot of potential causes, ranging from renal causes, drug-related causes, endocrine causes, cardiac causes, pulmonary causes, even neurological causes, and even pregnancy. So let's go through these potential causes one by one. So starting with the renal causes. So firstly, we can have problems with like the renal vasculature. So for instance, we could have like renal fibromuscular dysplasia, or we could have like renal artery stenosis. So with these conditions, what we have is we have like a decrease in blood flow towards the kidneys. And remember that our JG cells would interpret this decrease in perfusion to the kidneys as decrease in blood pressure, and therefore they would release renin as a compensatory mechanism. So they release renin, and renin contributes to the production of angiotensin II, and angiotensin II does a whole lot of actions, increasing our blood pressure. So that can be one of the mechanisms that a renal problem causes hypertension. The second problem we may have in the kidney is actual damage to the renal parenchyma, or like the small vessels in the kidneys, like in the nephrons, and damage to the tubules or the glomeruli. So for instance, if we have like a diabetic patient, we can have like renal nephropathy, or like maybe polycystic renal disease, or like what's a good one, glomerulo nephritis. So in these situations, in these diseases, we damage the tubules and the glomeruli themselves, and that reduces the GFR, or the glomerular filtration rate. And because we've decreased the glomerular filtration rate, again, we stimulate the JG cells, they'll release renin, and then that's gonna produce angiotensin II, which will then increase our blood pressure. The next potential cause of a secondary hypertension can be drug-related causes. So for instance, if someone has like taken a lot of sympathomimetics, so sympathomimetics are just drugs that mimic the action of the sympathetic nervous system. So like cocaine or methamphetamines. So increase in the sympathetic nervous system means an increase in heart rate, an increase in contractility, which means that we have an increase in stroke volume, an increase in cardiac output, and therefore an increase in blood pressure. Also, with sympathomimetics, they basically promote the vasoconstriction of our vessels, which increases total peripheral resistance and therefore blood pressure. The next pharmacological agent that can trigger hypertension is like oral contraceptives, especially the ones containing estrogen, because estrogen works in the liver. It increases the production of angiotensinogen, which is the precursor for angiotensin I. So angiotensinogen is produced in the liver, and angiotensinogen is converted to angiotensin I by renin, and then angiotensin I travels to the lungs, gets converted into angiotensin II by the ACE enzyme. So if we have more angiotensinogen, we have potentially more of these substrates that can be converted to angiotensin II, and angiotensin II increases our blood pressure. The other pharmacological agent it's very common actually, NSAIDs. So we use this as analgesic agents like painkillers. So NSAIDs like ibuprofen, for instance. The problem with this is that they block the COX enzyme. So the COX enzyme, it's involved in many different things, but the COX enzyme, the one that's relevant for this, is it produces prostaglandin I1, so PGI1. And PGI1, it dilates the afferent arterial in the nephron. So if we block COX enzyme, we block the production of PGI2, which means instead of vasodilation, we get vasoconstriction of the afferent arterial in the nephron. And this decreases the GFR, which then triggers the production of renin, which then triggers the production of angiotensin II, which increases our blood pressure. The third potential cause of a secondary hypertension is endocrine causes. So we can have problems with either our adrenal glands or our thyroid. So adrenal problems can include like hyperaldosteronism, So in this problem, we have a high production of aldosterone. So with aldosterone, remember that aldosterone promotes the reabsorption of sodium and water, which increases our blood volume, which then increases our blood pressure. And one thing I forgot to mention about aldosterone is not only that it promotes the reabsorption of water and sodium, it also promotes the excretion of potassium and protons. So in hyperaldosteronism, we also get metabolic alkalosis because we're getting rid of that proton, and we're also getting rid of the potassium, okay? So another adrenal problem that may contribute to secondary hypertension is Cushing syndrome. So Cushing syndrome is a problem with cortisol. So we have high cortisol production. And what cortisol does is it makes the receptors for norepinephrine and epinephrine more sensitive to them. And therefore, we get like a heightened sympathetic nervous system activity once these hormones bind to those receptors. So we get an increase in contractility, an increase in heart rate, an increase in total peripheral resistance, which all contribute to the increase in blood pressure. The next adrenal problem can be pheochromocytoma. So in this condition, what we have is we have like a tumor, a mass in the adrenal glands, which makes the adrenal glands release more epinephrine and norepinephrine. And with that, we get increased sympathetic nervous system activity, we increase the heart rate, we increase the contractility, which increases stroke volume and increases blood pressure, and we also increase the vasoconstriction of the vessels, leading to increase in total peripheral resistance and therefore increase in blood pressure. The other set of endocrine problems that can lead to hypertension are problems with our thyroid as well as parathyroid. So believe it or not, hyperthyroidism and hypothyroidism can both lead to hypertension. So what happens in hyperthyroidism is we have an elevated levels of T3 and T4, and those increase our heart rate and therefore increases our cardiac output and therefore increases our blood pressure. But a high level of T3 and T4 decreases the tone of our vessels. So this is why hypothyroidism can lead to hypertension, because if we have decreased levels of T3 and T4, we have an increase in the tone of our vessels. So if we increase the tone of our blood vessels, that increases total peripheral resistance, which then contributes to an increase in blood pressure. So that's how hyper and hypothyroidism can both lead to hypertension. The next one is problems with our parathyroid. So we can have hyperparathyroidism. So in hyperparathyroidism, we have an excess parathyroid hormone, so excess PTH. And PTH works by increasing the calcium in our bloodstream. And these calcium can actually kind of flush into those smooth muscle cells of our vessels, making them vasoconstrict. And if we vasoconstrict our vessels, we reduce the lumen of those vessels and we increase total peripheral resistance, and therefore this can lead to an increase in blood pressure. The fourth potential cause of a secondary hypertension is like cardiac causes. So for instance, if we have a coarctation of the aorta. So in coarctation of the aorta, imagine the aorta as it comes off the left ventricle. It has that arch bit, and then it goes down, has a descending portion which then delivers blood to the lower extremities. So in coarctation of the aorta, we have a portion of that tube that's narrowed. So we call this the constriction ring. So proximal to that constriction ring, the blood pressure will be very, very high. And distal to that constriction ring, the blood pressure will be low because the blood has to squeeze through that tiny, tiny gap, that small narrowed area in that constriction ring. So the blood pressure would decrease after the constriction ring. So what we get is a discrepancy between the blood pressure in our head and neck and upper extremities area and our lower extremities. So in the head, neck, and upper extremities, we would have high blood pressure, which we can feel this actually. We can feel this as like bounding, intense, strong pulses, whereas our lower extremities would have very weak, less intense, and even diminished pulses. And because we have low blood pressure going to the lower extremities and the organs of the lower half of the body, what happens is that we get a decreased perfusion in the kidneys. And decrease in kidney perfusion triggers the release of renin from those juxtaglomerular cells. And an increase in renin production means an increase in angiotensin II production, which then means an increase in blood pressure. So now we have triggered hypertension. We have triggered secondary hypertension. The fifth potential cause of hypertension can be from pulmonary causes. So for instance, if we have like obstructive sleep apnea. So in obstructive sleep apnea, we go through periods of apnea when we're asleep. So during those periods of apnea, we're not breathing in oxygen and we're not breathing out carbon dioxide. So what happens is that we have low oxygen and we get high carbon dioxide building up. So we get hypoxemia, low oxygen, and we get hypercapnia, high CO2, which both triggers an increase in sympathetic nervous system activity. So if we increase our sympathetic nervous system activity, we increase our blood pressure. The sixth potential cause of a secondary hypertension can be like a neurological cause. So for instance, if we have an increase in intracranial pressure, that causes a reflexive increase in blood pressure. So, we have a fixed space in the skull. So if we have anything there that shouldn't be there, whether that's blood or like fluids or like a mass or an abscess. So if we have like a hemorrhage in the brain, blood, or if we have like a brain tumor, like a mass or an abscess, that increases intracranial pressure. So patients with these kind of problems may present to us like with the Cushing's triad. So the Cushing's triad is like a set of symptoms that enables us to know that there is an increase in intracranial pressure. So Cushing's triad include increase in blood pressure, bradycardia, so low heart rate, and irregular respirations. And finally, pregnancy can actually trigger secondary hypertension. So we have two common conditions like preeclampsia and eclampsia. So this usually happens around about after 20 weeks of gestation. So the presentation could be, we have a female pregnant patient after 20 weeks of gestation coming in with really high blood pressure and proteinuria. So these are symptoms of preeclampsia. So eclampsia is similar. They have essentially the same symptoms, but with the addition of seizures. So in eclampsia, the patient will have high blood pressure, would have proteinuria, and seizures. Now that we know the different causes of hypertension and the difference between essential and secondary hypertension, let's now move on to the complications of hypertension. So if a person has chronic hypertension or just really sudden acute severe hypertension, these are some of the complications. So we can have neurological complications. So for instance, because of the high pressure, we can have aneurysms. We can have like berry aneurysm that can rupture and cause a subarachnoid hemorrhage. We can have Charcot-Bouchard aneurysms that can rupture and cause like an intracranial hemorrhage. We can have like, because of the really high pressure going through those small capillaries in the brain, they can leak out some of the fluid inside the capillaries, so they can cause something called PRES or Posterior Reversible Encephalopathy syndrome. So this is the high pressure basically causes the capillaries to leak out some fluids, and this causes vasogenic edema. We can also have retinal complications, so we can use a fundoscope to look at the retina. So some of the complications of hypertension that can manifest in the retina is like AV nicking. We can also see like increase in exudates that's being leaked out from the capillaries, and we may even see papilledema or the swelling of the optic disc. We can also have cardiac complications, so we can have coronary artery disease resulting from hypertension. So for instance, if for instance we have like plaques that are inside the coronary arteries because of the high blood pressure, that exerts like shearing forces against the vessel wall and against these plaques that are like inside the coronary arteries, meaning that these plaques can rupture because of that shearing force being applied by the blood. And when they rupture, they attract platelets, and then platelets, they aggregate, and then a thrombus forms on top of that plaque, causing like a near total occlusion or a complete occlusion of the coronary artery, leading to ischemia and infarction. So that's one of the complications because of high blood pressure. Another cardiac complication can be like diastolic heart failure. So because we have such high blood pressure in the systemic circulation, we have a high afterload. This means the left ventricle of the heart needs a higher pressure to overcome, and therefore it adapts by becoming thicker. Because there's a greater pressure it needs to overcome, it needs to be thicker to generate more force to contract that blood out to overcome the afterload, the high pressure. So it becomes thicker, and therefore this makes it more difficult to fill the chamber because the myocardium has like extended through the chamber space, making the chamber smaller, and therefore it doesn't fill as much blood. So we get a filling problem. We get diastolic heart failure essentially. And because we have a diastolic heart failure, the blood is not going into the ventricles so much, they can back up to the pulmonary circulation, causing pulmonary edema. Another cardiac complication of a chronic, long-standing hypertension can be atrial fibrillation. So let's follow on from my previous story. So because we have such a high afterload, because of the high blood pressure in the systemic circulation, the left ventricle compensates by becoming bigger. And therefore, the musculature extends and kind of like fills in the chamber space, making it more difficult to fill it with blood, causing diastolic heart failure. At the same time, because that ventricle has become thicker, the pressure is greater, and therefore our left atrium needs to get bigger as well to force that blood into the left ventricle. So the left atrium also hypertrophies, and because it's gotten bigger, it alters the electrical conduction system in the left atrium, causing like ectopic foci to appear, and therefore causing arrhythmias, and then we can get atrial fibrillation. We can also have vascular complications, so we can get like an aortic dissection because of really high blood pressure. So this can happen because there's such a high blood pressure, there's a lot of shearing forces exerted against that tunica intima of the aorta, which eventually the tunica intima can rip, and blood can then go through the vessel, dissecting the vessel wall, creating like another pathway for the blood, dissecting that aorta. So it can cause aortic dissection. Another one is it can cause like aortic aneurysms. So because of the high shearing forces exerted against the vessel walls, they become weaker as a result. And because they're weak, they start to become floppy, and then they dilate, they form aneurysms. So we can also get aortic aneurysms. Another potential vascular complication because of hypertension can be like peripheral arterial disease, or PAD. So this can happen because, again, we have such high blood pressure. We are more at risk of atherosclerosis, forming those plaques inside the arteries. And if we get these plaques in the arteries, like in the lower extremities, then we can get like peripheral arterial diseases, and this can manifest as, for instance, like pain in the calf region when we're exerting, when someone is running, or when they elevate their legs. So this pain is called claudication, or intermittent claudication. We can also have renal complications. So because of the high blood pressure, some of the vessels supplying like the nephrons and things, they can thicken because they need to compensate for the high blood pressure. They thicken. It's called arteriosclerosis, and this means that like it's going to be harder for the blood to get through those arteries, and it causes some of the cells in the kidneys to die, and then the kidneys will atrophy, leading to eventually kidney failure. Another one is that because of such high blood pressure, some of those vessels in like the kidneys, they can burst, they can rupture, and therefore we can leak blood out to our urine, as well as proteins, because if we've damaged those capillaries, it's going to allow proteins to pass through, whereas normally it wouldn't. So we can leak blood and protein out our urine called hematuria and proteinuria. More specifically, it would be albumin that's going to be leaked out into the urine, so we will get albuminuria. And finally, a big complication from hypertension can be a hypertensive crisis. So there's two different terms we need to define and differentiate. So we have hypertensive urgency and we have hypertensive emergency. So hypertensive urgency means that the patient's blood pressure is above 180 over 120, but without target organ damage. With hypertensive emergency, the patient's blood pressure would be higher than 180 over 120, but here we have we're starting to show signs of target organ damage. Now let's move on to the treatment of hypertension. So we have different pharmacological agents that we can use, but firstly what we need to do is to prescribe lifestyle modifications. We advise the patient on changing some of the lifestyle that like risk factors that could be contributing to their hypertension. So we first tell them to try lose weight if they can. So lifestyle modifications is prescribed to all patients, and this is the first thing that we do. So we tell them to lose weight if they can. We prescribe the DASH diet. We prescribe like a low sodium diet. We tell them to just be more active, exercise a bit more. We tell them to limit their alcohol intake and to stop smoking. If lifestyle modifications aren't sufficient, or if the patient's blood pressure is over 140 over 90, or if their blood pressure is over 130 over 80, but with like significant cardiovascular risk factors, we start them on medical management. So we prescribe drugs to help manage their hypertension. So the first line drugs that we use for hypertension include ACE inhibitors, ARBs, dihydropyridine calcium channel blockers, and thiazide diuretics. Starting with ACE inhibitors, so examples of these include anything that ends with pril, so captopril, enalapril, lisinopril. ACE inhibitors are good for patients with like diabetes, chronic kidney disease, coronary artery disease, and even heart failure. So, but we have to be careful about some of the side effects. So they can get a dry cough and angioedema. So we have to be careful giving this to patients with respiratory problems like asthma or COPD. If they cannot tolerate ACE inhibitors, we can replace these with ARBs, or angiotensin receptor blockers. This includes like losartan, valsartan. So both ACE inhibitors and angiotensin receptor blockers, they work by trying to stop the production of angiotensin II, which does a lot of things to increase our blood pressure, including increasing our heart rate, increasing our contractility, and vasoconstriction to increase blood pressure, as well as stimulating the release of aldosterone, which increases sodium and water reabsorption, and stimulating the release of ADH, which increases water reabsorption, all contributing to high blood pressure. ACE inhibitors and ARBs are good if our problem is because of high renin, okay? If we have low renin hypertension, so for example, this is more prevalent in patients who are of African American descent, then we can prescribe other first-line medications like dihydropyridine calcium channel blockers. So examples of these include amlodipine and nifedipine. So they actually work like directly onto the vasculature, so they dilate the vessels. So if they dilate the vessels, that decreases total peripheral resistance, which therefore decreases our blood pressure. And as I mentioned, this is good for patients who doesn't have any, like, their problem isn't about renin. Their problem is maybe because they have high sodium retention. So this calcium channel blockers, especially the dihydropyridine types, are good in patients with low renin hypertension, more specifically in our African American groups. Another first-line medication that we can give to our patients is thiazide diuretics. So thiazide diuretics include hydrochlorothiazide and chlorothalidone. So these medications, what they do is they excrete sodium. They promote the excretion of sodium and water into our urine, therefore decreasing blood volume, therefore decreasing our blood pressure. So as I said, we give this in patients with low renin hypertension, because in this group of patients, their problem isn't because of renin, their problem is because there's high sodium retention. So we give this to them, and this is actually also very good for patients with osteoporosis, because thiazide diuretics, they promote the reabsorption of calcium into the bloodstream. So it's gonna help with patients, it would be beneficial for patients with osteoporosis. But we have to be careful giving these to patients with gout, because they increase the concentration of uric acid, which is the main problem in gout. Some of our second-line medications include beta blockers and aldosterone antagonists. So beta blockers, they are good for patients with coronary artery disease, with heart failure, and even with atrial fibrillation, with really, really high heart rates. So examples include metoprolol and carvedilol. Metoprolol is more cardioselective. So we need to be careful giving this to patients with like asthma and COPD, because especially if it's a non-selective beta blocker, it can block some of the beta receptors in our lungs, causing like vasoconstriction of the airways, making the asthma or COPD even worse. We also need to be careful. We don't give this to patients with low heart rates, so bradycardic patients. We don't give this in patients who have decompensated heart failure with really low like ejection fraction, because what beta blockers do is they reduce the contractility of the heart. So if they reduce the contractility of the heart, then it's definitely not going to generate enough force of contraction. It's not going to help generate enough stroke volume. It's therefore not going to improve the cardiac output. So we avoid this in patients with decompensated heart failure. Another thing is that we avoid this in patients who are hypoglycemic, low blood sugar, because if someone is hypoglycemic, they start having sympathetic nervous system like reflex response. So they start becoming sweaty, so they start having diaphoresis or increased heart rate. And if we give them beta blockers, we essentially block that response, that sympathetic nervous system response, and therefore we mask their hypoglycemia, which can be dangerous and fatal to the patient. So we don't give this in patients who are hypoglycemic. The next one is aldosterone antagonist. So an aldosterone antagonist, an example could be like spironolactone. These are good in patients with coronary artery disease and heart failure. But we avoid this in patients who are hyperkalemic, high potassium levels, because spironolactone is potassium sparing, so it's just gonna increase the concentrations of potassium even more. If we have a pregnant patient, there's only 4 medications that we can use. So I like to use the mnemonic: healthy mums love nifedipine. So the first letter corresponds to the medication. So healthy, H, we use hydralazine. Mums, M, we use methyl-dopa. L, loves, we use labetalol, and nifedipine is nifedipine. So we can use hydralazine. Can't say my own acronym. So healthy mums love nifedipine. So hydralazine, methyl-dopa, labetalol, and nifedipine. Those are the 4 that we can use for pregnant patients. We shouldn't give them ACE inhibitors or ARBs because they are teratogenic. We should also avoid thiazide diuretics, because decreasing the blood volume may potentially decrease the placental perfusion. And finally, let's discuss how we're gonna treat a patient with hypertensive emergency, like in a hypertensive crisis. So again, the definition of hypertensive emergency is blood pressure of greater than 180 over 120 with target organ damage. So in this kind of situations, we have to use IV medications to drop their blood pressure really quickly, but we need to be careful in dropping their blood pressure really quickly. So usually we try to drop their blood pressure by 25% in the first hour. And then when they tolerate that treatment, we try drop their blood pressure even more. Their systolic to like lower than 160 millimeters of mercury in the next 2 hours. And then if they still are okay with that, we try drop their blood pressure even more to what their baseline value was within the next 2 days. So again, we drop it to 25% in the first hour, then we drop it to less than 160 systolic in the next 2 hours, and then we further drop it to baseline within the next 2 days. The reason why we don't just drop their blood pressure super quickly is that we risk ischemic complications. So imagine you have like a high blood pressure, which means hyperfusion to the tissues, and if you suddenly drop blood pressure, then this can like decrease perfusion to the brain significantly, so we might get like a stroke. This may decrease perfusion to the myocardium significantly, causing an MI. It can, decrease the perfusion to the kidney significantly, causing an acute kidney injury. So we have to follow this step-by-step protocol in reducing the patient's blood pressure during a hypertensive emergency. So the IV agents that we actually give them include nicodipine and labetalol. So nicodipine and labetalol are the most common ones used as like IV agents during a hypertensive emergency, but we can also use hydralazine and nitroprusside. But again, nicodipine and labetalol are the most common ones.